Okay, everybody, we're on chapter 10, respirations and artificial ventilation. Now, everything we've taught so far is definitely important, and I don't want to take any of that away, but we're going to start getting into some chapters that everything will be critical and test points. Respirations and ventilation, this will be one of the most common things that we see in the field. I've seen more airway issues and ventilation issues and hypoxia and all that kind of stuff than anything else in the field. Now, it could have been trauma that caused it or diseases, but it's the main is a big part of what we do. So to understand the physiology and pathophysiology is going to be very important. Now, if you go to YouTube, like I said, I sent a message to Memorial that they sent me a bunch of videos that don't work. Um, but again, go to type in this in YouTube, oxygen administration via non-rebreather mask video, and there's a good one on that for it's emt.com, emtprep.com. Um, and utilize that and watch some of these videos, even if I can't get them to you. Um, and then also the intubation in hospital endotracheal intubation video. We don't intubate, but it's good to know how. So going through the physiology and pathophysiology, respirations, positive pressure ventilation, all that stuff we're going to cover today. But they are really important. And again, I want you guys know I appreciate the time that you're taking to do this class. I can't tell you, it's just so important, and I'm excited for you. Stick with it, and we're going to keep trying to use these videos to make it easier for you. So ventilation, the mechanics of breathing. Ventilation is the process of moving air into and out of the chest. So that's all it is. But you're going to have to know the difference between ventilation and respirations. It is definitely a test point, and it is a tricky one because we think respirations and ventilation sometimes is the same thing, and it is not. Ventilation is the process of moving air into and out of the chest. Another test point is inhalation. This is an active process. And I want you guys to think for a second, like we're actively breathing, right? We don't, but our brains, we breathe without thinking about it. It's just the way our bodies are designed. But it is active when we breathe in. And when we breathe in, the muscles expand, the size of our chest increases, and all that negative pressure pulls air into our lungs. So it's important to understand. So if anything changes that negative pressure in our chest, it affects our inhalation. But again, muscles expand, size of chest increases, negative pressure pulls air into the lungs. Now, exhalation is the passive process. So it's not active, it's passive. Your muscles relax, the size of the chest decreases, positive pressure created, air pushed out. So positive pressure is created, and then the air is pushed out of our chest, out of our lungs, and goes throughout our body, or we breathe it out. So important to understand exhalation and inhalation. Inhalation active, exhalation passive. Um, Test worthy. Tidal volume. So that's the amount of air moved in one breath. So just like when we check our heart, right? We check our heart rate at radial, um, carotid, whatever, and we hear those beats. Bum, 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 bum. Well, we do that for 10, 15 seconds, then we multiply it by 4. And if we do it 15 seconds, we multiply it by 4. And that gives us our minute, our heart rate. So minute volume is the amount of air moved into and out of the lungs per minute. Total volume is the air moved into one breath. Minute volume is that multiplied into a minute. And it's important to understand dead air space or dead space air, whatever you want to call it, is air moved in ventilation, not reaching alveoli. So everything about breathing is to reach the alveoli. So this is in your chapter. Read it. It's about page 217, I believe, and 216, and it is important. So when you're breathing and you breathe air in, so you breathe in and you fill your lungs, right? So just take a picture in your mind. You breathe in, your muscles expand, your chest expands, and the air comes in, and it's to flood that alveoli. So dead space air is anything that doesn't reach that alveoli. And all of us have air that doesn't reach our alveoli. What we want is for a typical tidal volume for our a normal tidal volume for someone normal size, 5 to 7 milliliters per kilogram of body weight is what we want. So 5 to 7 milliliters of good tidal volume per kilogram for our body weight. Now, in EMS, we work in a lot of kilograms, and I'm not sure why, but we do. Um, but the point is that we always have dead air that doesn't reach our alveoli. The point, though, is we want as much to reach the alveoli as possible. So out of 500 milliliters, is only about 350 milliliters reaches the alveoli in a normal tidal volume. So if we don't get that, things start to go south. So the issue is that when the alveoli is reached, um, the gases are exchanged. The air dumps off the carbon dioxide, and it's like a filter. It knocks off all that gas. It unloads it all, and then it picks up good oxygen and the blood, and it loads onto the blood, and the blood takes it through the body, and it starts to take it to the cells. So it's important is good perfusion means that the blood is able to pick up good oxygen and take it to the cells and saturate our body with good O2. So anything short of that starts to cause some contemplations. So it's called alveolar ventilation, refers to how much air actually reaches that alveoli. So a normal tidal volume for a normal person, like I said, is 5 milliliters times 16 breaths per minute. It equals 8,000 milliliters. That's normal tidal volume. Now, normal alveolar ventilation. So tidal volume is the 500. Now, just bear with me. So the normal alveolar ventilation is 350 milliliters. So 500 is the volume, but 350 of that reaches the alveoli, and that leaves 150 dead space air. So we got to look at those things. Now, dead space air is the air in the trachea. It's parts of your lungs that didn't get to the alveoli, but that's a normal dose. So you take an asthma attack tidal volume. It usually is about 300 mLs times 16 breaths per minute equals 4,800. So you can see the drop off between 8,000 and 4,800. It's almost half. So the asthma attack alveolar is going to be less ventilation. So it's going to be 150 mLs. The tidal volume, but 150 dead space air. So it's not going to adequately perfuse the body at 2,400 mLs. So you can look at those kind of deals with asthma and those kind of things and realize their alveoli is not being reached. And then it's our job to figure out how to intervene to saturate that alveoli and get that body perfusing. A lot there in that chapter, in that 2 pages. So you're going to want to really dissect it, highlight it, do whatever it takes to help you remember. So the movement of gases from an area of high concentration to an area of low concentration is called diffusion. So now we're going to, you got the movement of gases from an area of high concentration to an area of low concentration is diffusion. The diffusion of oxygen and carbon dioxide that takes place between the alveoli and circulating blood is called pulmonary respirations. That's where carbon dioxide is offloaded from the blood into alveoli, while oxygen from the air in the alveoli is loaded onto the hemoglobin of the blood and transported to the cells. At the cells, through a similar but reverse process of diffusion, oxygen passes from the blood across cell membranes and into the cells, while carbon dioxide from the cells passes into the blood. So the fusion of oxygen and carbon dioxide that takes place between the cells and circulating blood is called cellular respirations. So ventilation is the tidal volume that you breathe in with one breath. Okay. Now, cellular respirations is where the oxygen and carbon dioxide that takes place between the cells with the blood exchange. Gas is unloaded, oxygen loaded, blood takes the oxygen to the body. Is cellular respirations, and it happens on a cellular level. So it's important to understand those differences. So with that said, I'm talking a lot there. I need to move on. But external respiration, so diffusion of oxygen and carbon dioxide, the exchange of gases between alveoli and circulating blood. So very important to understand that process. So I'll just say a real brief one more time. That's where the gases are dropped off, unloaded, and good oxygen is loaded on the blood and into the hemoglobin, and it takes it to the body like a bus. And that's just basically how it works. So anything that interferes with that will change that process. Internal respiration is exchange of gases between blood and cells. Cellular respiration, oxygen from blood diffused into cell, carbon dioxide diffused from cell into blood. So there you go. Just a little bit of repetition there, but it's going to be so important. So if the mechanics of breathing is disrupted, gas exchange interrupted, circulation issues. All those things happen if anything affects that area. So it's a stab in the chest, stab wound. When the diaphragm moves downward, air is pulled into the chest cavity through the stab wound in addition to the normal drawing in. So basically, if that so basically if anything happens, that will affect that. So if a stab wound, the air is going to that hole in the chest will really affect that pressure, and it's going to change how that air gets into the lungs. So it's important to understand. A patient will lose. A lot of things can happen. As a patient may lose the ability to transmit messages through the nerve tissue, um, and stop that muscles from helping the respirations. This can occur with MS. A lot of MS, you can see there's a lot of autoimmune diseases, MS and Parkinson's and all that kind of stuff. Any of that will affect those muscles being able to do its job when the body can't communicate through the nervous system. Um, all of it's oxygen driven. A patient, chest wall injury. Physical damage can limit the chest wall movement. If you got a steering wheel to the chest, someone fell down the stairs, a pneumothorax, all kinds of stuff that will affect that chest pressure. So again, you got to think of the body like a machine. If the body is a machine, and that thoracic, that chest cavity is designed to protect those lungs and get air in like a machine, dump off the carbon dioxide or the gases, load the blood on, or load the good O2 onto the hemoglobin and take that through the body to perfuse it. And so any kind of thing that affects the way that chest cavity is designed will affect the pressure and go from there and um, change everything. A patient has airway problems such as bronchoconstriction, COPD. I know when my dad passed away, I wasn't an EMT yet, and so it wasn't on my radar a little bit. But I lived here. He lived in Michigan. Mom called me one day and said, "Man, your dad really doesn't look good. He's not feeling good for weeks. His lips are blue, and he's just too sick to go to the doctor." Well, he died the very next day from my mom calling me, and basically what it was is he was hypoxic for weeks, um, and with hypoxia came his brain wasn't functioning, so he literally was confused and didn't know what to do, and he wasn't perfusing. And so, short thing is, a long story short is his bronchial tubes were decreased in diameter, so it was affecting that tidal volume, which was affecting that um, alveoli exchange, and it affected how his body was perfusing, and eventually caused a cardiac arrest from a respiratory arrest. So anything like that can affect the process that the body was designed to do. Diffusion problems, some diseases such as congestive heart failure and COPD limit the ability of alveoli to exchange oxygen and carbon dioxide. Here, oxygenated air and blood reach the alveoli, but the alveoli themselves are not working. So, boom. Read this chapter as thoroughly as you can. So, respirations. Remember, there's a difference between ventilations and respirations. Brain and body cells need a steady supply of oxygen. If not, hypoxia kicks in, which is low oxygen level in cells. So you got to remember is when you're breathing, it's all cellular level. You breathe in air, gas is unloaded, good oxygen is picked up, the blood takes it to the body, to the cells at a cellular level. So if those cells are not getting that blood with that oxygen, you will be hypoxic. Carbon dioxide must be continuously removed at that alveoli level, and if it's not, you're hypercapnic, and high carbon dioxide level is the reason. So if that's not happening, it's a downward spiral from there. It's not a great day for you. Adequate and inadequate breathing assesses how well cardiopulmonary system is accomplishing oxygenation and carbon dioxide removal. So if you're adequate and inadequate, so adequate is basically what we do is we assess how well cardiopulmonary system is accomplishing oxygenation and carbon dioxide removal, and we'll talk about how to do that later on in this chapter or next. But there is a few ways that we monitor those things and then intervene as we can. Compensation for hypoxia or hypercapnia is predictable. Signs is shortness of breath. As a symptom, increased respiratory rate, so your body's trying to compensate, right? So just like we said, if your heart rate's high, it's compensating. If it's if your respiratory rate's high, it's compensating. But if you got someone that's breathing at 40 breaths a minute and they're shallow, they're not going to get that good alveoli exchange. So you're going to have to intervene with that. Increased heart rate. So basically, the compensation there is your heart's beating faster because it's trying to get more blood to carry oxygen. But the point is that the blood is not getting enough oxygen exchange. So it's not the blood flow problem. It's the pulmonary. It's the pulmonary problem. It's at the alveoli level. It's not exchanging properly because there's not a good tidal volume of air starting the process. So, but those are the compensations: shortness of breath, increased respiratory rate and depth, and increased heart rate. Early on, steps of adjustment can meet the needs of the body despite respiratory challenge. And that is true. The earlier that we can get to some of these folks, the better it is for them because we can intervene at an earlier level and help them quicker. Respiratory distress is not a pretty thing. Body compensating for a respiratory challenge and meeting metabolic needs. So the issue is not happening. Um, so you're in respiratory distress. You're not in arrest. You're in distress. That means you are getting ready to go to rest, but your body is strained. You're not. So your body begins compensating for the challenge. If it's COPD, if it's pneumonia, what are some other ones? Asthma, all those kind of things. Like I said about the trucker, he's that TA I went to a while back, and he was totally in distress. He's pouring out sweat. His breaths were rapid and shallow, and he couldn't do anything else but focus on breathing. Um, and so he was compensating for a problem. And it turned out he had some kind of lung infection that he was being treated for before, but it just didn't get better. And so he was in distress at that point, and we had to intervene, and we did. We gave him a non-rebreather with some albuterol, pump it into him, and with nebs, and so he got better. But occurs when challenges are too great for body's compensation mechanism, and also known as respiratory failure. Now, failure and arrest are different as well. You're on a downward spiral. Exceptionally important to recognize, often a precursor to respiratory arrest, like I said. And that's not, that's it's just common sense to understand if you're in failure and you stay there, pretty much you're going to shut down. Um, and that will definitely happen. So here's the stress. The tripod position is what we call it. There's a nope, that's a albuterol treatment that she's going through right there. And but basically she's tripoding, and if you see this kind of person, they're tripoding, they're deep breathing, they're not deep breathing. Some of them can be deep breathing, trying to just gasp, And but she probably was shallow and rapid breathing when you come into the room and see her. Um, so some signs of this is relatively normal mental status. They're in distress. They're not in failure or arrest yet. Um, Signs of adequate breathing, though, can be the relatively normal mental status. You haven't lost that mental capability. If you get someone that's in a respiratory failure and in distress, and in those phases, they're mentally altered. You ask them their name, they can't tell you. You ask them where they are, they don't know, just because they don't have good enough oxygen being perfused to their body. Relatively normal pulse ox reading, 94 to 90 is a decent reading. Relatively normal skin color, skin usually pink, warm, and dry. Um, Signs of inadequate breathing, though, is chest movement are absent, minimal, or uneven. Um, and that is definitely the case. If they're rapid breathing, their chest isn't moving that much. Abnormal breathing, shallow, short, barky. Um, no air can be felt or heard at the nose or mouth. Uh, Breath sounds are diminished or absent. Wheezing, crowing, stridor, gurgling, or gasping during breathing. All those are signs of inadequate breathing that you will check when you're doing your assessment. Um, Rate of breathing is too rapid or too slow. So the point is that you want to have that perfect balance, because sometimes it is important for us to get the person doing more breathing, speed up that rate per minute. But at the same time, if they're doing too fast, they're not getting deep enough. If they're too slow, they're not getting enough tidal volume. So there's that happy medium that we want to find as EMS when we're there to get them getting that alveoli exchange. And you can help that. If you're bagging someone, for example, you want to make sure not to be doing it too fast because your adrenaline's going. You want to do a nice breath, nice breaths, good chest rise, fill those lungs up, get that alveoli exchange happening, that gas exchange at the alveoli level, and help. And we'll teach on that some more. But cyanosis, that's they're blue, they're cyanotic. Like my dad was cyanotic when my mom was telling me that he was blue. Inspirations or expirations are prolonged, so they exhale and they just keep exhaling. They inhale, same thing. Um, Retractions at nasal flaring in children. So yeah, retractions at the clavicles and nasal flaring in children are a big sign. Low oxygen saturation reading, 95% is, for test purposes, stick with what you see in the book. 95%, 94%, perfect. That's what we want. And they'll say anything below that, it's hypoxic. Really, it's anything below 90, I start to consider we got to intervene um, with their pulse ox. But for test purposes, make sure 94, 95%. Hypoxia, major causes. My patient is trapped in a fire. A patient has emphysema. I mean, that was big. My grandpa had emphysema, and he was hypoxic the whole time I knew him before he passed away. A patient overdoses on a drug that has a depressing effect on the respiratory system. You'll see that. A lot, I mean, it's getting worse. I'm not gonna lie. I've seen a lot more of it in our county in the last few years um, than I would like to say. But you will see this, and basically any opiate that they take, it's going to lower the respiratory rate, and we have to intervene with that. Patient has a heart attack, inadequate breathing, provide artificial ventilation to the non-breathing patient and the patient with inadequate breathing. So inadequate breathing. So provide artificial ventilation to the non-breathing patient and the patient with inadequate breathing. And there's many ways that we'll do that, and we're going to teach on that. But provide supplement oxygen to the breathing patient. And excuse me. And it's in your book as well on what are some things that we want to do. Um, there's definitely things that we can, some of the things that we intervene with, you know, with people that are inadequate. Give an example is oxygen by non-rebreather mask or nasal cannula is definitely the two most common ones that we use. Assisted ventilation is air forced into the lungs under pressure with a pocket face mask. I mean, I've never used a pocket face mask, but a bag valve mask is a big one. And we'll see the chapter text about adjusting rates and rapid or slow breathing. It's in the book that we want to make sure to know. Um, but some science to use a BVM is, the patient has some breathing, but not enough to live. Rate and or depth outside of normal limits. Shallow ventilations, diminished or absent breath sounds. Noises such as crowing, stridor, and all that kind of stuff, which we talked about with inadequate. So basically, repeating the slides that's in your book. But the BVM mask is something that we use to control the person's breathing. We're not just trying to give them air, but we want to control those ventilations, whether unconscious or conscious. And we'll get to some more on the adjustments of those things. And so artificial ventilations, common, like I said, what we use is the non-rebreather and nasal cannula, but always be ready. If there's no chest rise and no evidence of air moving, we're going to start breathing for them. On chapter 222, you'll see some pictures, and we're going to go through it in class hands-on, the nasal cannula, non-rebreather mask, the BVM, and we did a little bit of that with Annie the other day with the BVM, and it's a science. You want to do it properly and make sure, like I said, to get good ventilations, deep breathing, get the chest rise expanded, and so get that good chest rise, fill those lungs, get that alveoli exchanged. So when do I intervene? Often respiratory failure patients will be breathing and conscious. So when do I intervene with those things? Well, if they're in, if the respiratory failure, if they're breathing and conscious, you want to help them with their oxygen intake. So obviously you just intervene. I'm looking through the book to make sure if they have a certain point that they're trying to make with that, but because sometimes it is, and I'm just trying to make sure to give the right information here, but sometimes it could be difficult to determine when a patient does need intervention. Often patients in respiratory failure will be breathing and conscious, but it is important, however, to identify not just the presence of breathing, but the adequacy of breathing. Even though the patient may still be breathing, if he is displaying the signs of inadequate breathing, he absolutely needs your intervention. So, with that said, you know, if they're having difficulty breathing, you're going to intervene for them. Um, so basically, if you get a page for someone having difficulty breathing, and you show up on scene, and they're breathing and they're awake and they're alert, but they're struggling, you're going to intervene. It's just a matter of what you're going to do. Um, so there's a couple things to look at with that. Is if the ventilation is the breathing of air or oxygen. So artificial ventilation, also called positive pressure ventilation. We never call it this in the field, but it is positive pressure ventilation. Is forcing air or oxygen into the lungs when a patient has stopped breathing or has inadequate breathing. So that's us BVM, bag valve mask. We're breathing for them. We're filling that air, filling that chest. We're getting that chest rise, filling those lungs, getting that alveoli exchange. Um, so when you're doing the BVM mask, um, and you're breathing for them, one of the things that we want to look at is the force that you use is exactly the opposite of the force the body normally uses to draw air into the lungs. So we're not creating a different pressure, we're just mimicking what that body would normally do. Just small, small squeezes. And, normally the heart uses the negative pressure of ventilation to assist the filling of the chambers with blood. But when we use positive pressure, so the pressure I'm talking about to ventilate, we eliminate that negative pressure and filling assistance. So the heart can typically compensate the risk of causing the drop in blood pressure. Um, so make sure to read these pages really good. Gastric distension is the filling of the stomach with air. So you're not getting air into maybe you're getting air into the lungs, but you're also getting into the stomach, and their stomach gets larger and opening, and so it gets to be a tricky thing. So when that's happening, you want to reposition the head, tilt chin, whatever you're doing to open that airway, to try to get more into the trachea, which leads to the lungs, and esophagus. That's why intubation is so good that paramedics can do, because it goes straight into the trachea, where some of the stuff we do is EMS with eye gels or king tubes, compi tubes. Um, it will definitely get air into the stomach as well if you miss the trachea. But the point is, if you miss the trachea, you're still going to breathe for them. Where intubation, if you don't get the trachea, you're not breathing for them. So it's a complex thing there. That's not test for the intubation because it's not our scope. But to just remember that when gastric distension is taking place, when you're trying to breathe for them, that means the air is going through the esophagus, and so which leads to the stomach. So a larger opening is the trachea, which leads to the lungs, and the esophagus does not have a protective cap like the epiglottis. So anatomy, remember those things. Hyperventilation is when we take over ventilations, and for a patient, it is important to pay attention to the rate. There are any number of distractions and stressors that causes us to do those things. So when we're breathing for the patient, we want to make sure that we're keeping track. Um, you know, and I'm going to tell you it's about 8 to 10 breaths a minute. That has changed so many times, even in my time as an EMT, and I've only been an EMT for probably 5 years, but that has changed many times from 10 to 12, 8 to 10, 6 to 8. It's just whatever, but it's in your book, and I'm going to, so look up the exact numbers that the book tells you for test purposes, but really it's 8 to 10 breaths a minute. Eight's fine, and you want to make sure that you're getting one, you're doing that properly. If you hyperventilate them, you're going to cause different problems, and there's a lot of distractions, so we can forget. So usually, like for me, when I'm bagging somebody in the back of the ambulance, my job is to bag and watch the monitor, so I know exactly how they're doing. And with that, so if their pulse ox is dropping into the 80s, I'm not ventilating proper. If it's getting too high, I'm doing too much. So I watch that pulse ox, and I'm breathing, and somebody else is doing what they're doing. You separate your assignments. So anyway, so some techniques to artificial ventilation though is mouth to mask, two rescue bag valve mask, um, and then flow restricted oxygen powered ventilation devices, which we're going to teach on that. So don't worry too much about that right now. One rescue bag valve mask, and anyway, so those are just some some interventions. So think about this. What signs might identify the need to intervene in a breathing patient? Um, just think about that. I mean, I'm not there with you. We're not in class time right now. So think about that and answer it to someone around the house with you. but and work through a little bit together and think about it. Cyanotic, tripod position, shallow breathing, whatever. Um, there's a lot of them. So positive pressure ventilation, we just covered that a little bit, and we'll just keep going forward. But forcing air oxygen in the lungs when a patient has stopped breathing or has inadequate breathing. And then uses force, exactly the opposite of how the body normally draws air into the lungs. So there you go, I mentioned that earlier. Um, Negative side effects of positive pressure ventilation is decreasing cardiac output, dropping, and blood pressure. And that's just something that happens. It is a negative side effects. Gastric distension, like I said, the air's getting into the stomach, so you want to make sure to get through the trachea, and that goes right to the lungs. Hyperventilation, getting too much breathing too fast. So again, excuse me, if they're not breathing adequate, and then you're hyperventilating them, you're causing the same problem. The lungs aren't expanding. You're not getting good tidal volume into that lung. So without good tidal volume, you're not getting the percentage to the alveoli, and the gas exchanges ain't happening, and then the oxygen is not loaded into blood, and the blood's not perfusing the body. So you want to make sure to get the proper counts in there when you're breathing for them, and watch the monitor. Watch that pulse ox. Um, Do not ventilate patients who is vomiting or has vomitus in the airway. Suction that airway out. Keep them on their side as much as possible. Um, but positive pressure ventilation will force vomit into patients' lungs. So if they're already vomiting, it's going to get into their lungs because you're going to push them in there, and then that will cause a whole different problem. Watch chest rise and fall with each ventilation. Because you might have a good seal. If you guys who practiced on Annie, Annie's more complicated than a live human, but at the same time, it's a good practice because one breath you might have good chest rise, second one you don't. So you want to keep watching that chest rise, and every so often take your stethoscope and listen to all the four lobes. Make sure oxygen is getting in there. Ensure rate of ventilation is sufficient. Watch that pulse ox, watch their skin color, watch their pupils. Make sure ensure the rate of ventilation is sufficient, that you're doing for them. It's not hyperventilation, and you're not making them hypoxic. Carefully assess the adequacy of respirations, um, and explain procedure to patient. You let them know what you're doing. When you if you're putting a VVM mask to do positive pressure ventilation on a living person that's a conscious, explain what you're doing, because it's a scary process. They're in some ways they're losing control of what they're doing. They're not breathing adequate, but now you're putting a mask on their face. It's scary. It's uncomfortable. Explain it to them. Place the mask over the patient's mouth and nose. Make sure to get a good seal. And after sealing mask on patient's face, squeeze bag with patient's inhalation. So watch their, they're already breathing. So watch, okay. So when they're, just watch them. So when the patient inhales, inhale with them. Squeeze that bag. And get that going. Form of non-passive positive pressure ventilation is CPAP. NPPV, continuous positive airway pressure, just continuous. Then the BiPAP is um, in the BiPAP. I'm trying to remember BiPAP. Okay, so BiPAP is positive airway pressure, as well. And so two different things. So we kind of have, and we're gonna teach on CPAP just by itself. It is in our scope now. It didn't used to be. And how to do it. And if you have a CPAP machine at home, you basically know what you're doing. But at the same time, we do that a lot when even a BVM is not working. We got to get continuous positive pressure, and ventilation. And then the pocket mask. When you basically it's just a BVM. Same. It's a pocket mask, the mask that's on the BVM, but you don't have a BVM, and you just put it on their face and you breathe for them, with your mouth. And there you go, pocket mask. Mouth to mask ventilations. A lot of times people, first responders, EMRs, they'll carry that more than we will. I mean, I have a jump bag in my personal car, and I have one of those with it, and just in case. Patient without suspected spine injury. So, mouth to mask ventilation. Position yourself directly above the patient's head. Apply the mask to the patient and place your thumb over the top of the mask, your index finger over the bottom of the mask, and the rest of your fingers under the patient's jaw. And there's a picture of it in your book that gives you better detail than me rambling on about it. But it just helps secure the mask to get a good seal, so when you breathe, it doesn't leak out. And your book goes into way more details on some of these things, but I don't want to keep it too long. Performing mouth to mask ventilations, patient without suspected spine injury. So EMT at top of the patient's head, lift the jaw to the mask as you tilt the patient's head backward. And so basically it's just kind of the same thing as anything else. Open that airway. So backward and place your remaining fingers under the angle of the jaw. Use your hands to grab that jaw. So your fingers are under the jaw, your thumbs are over the mask, and you're sealing it to the face. So while lifting the jaw, squeeze the mask with your thumbs to achieve that seal. Then give breaths into one-way valve of the mask. So basically, like I said, it's the BVM mask. I mean, it's the same mask, but you don't have the bag to go with it. So your mouth replaces the BVM. So watch for the chest to rise when you breathe, and there you go. There's the picture of kind of what I was just explaining to you. So you can see the fingers under the jaw, thumb over the mask, head's tilted back so the airway's open and patent, and breathing in. Now the bag valve mask handheld ventilation device used to ventilate non-breathing patients and/or patient in respiratory failure. So there's some pictures we practiced with the other day from infant to adult. Standard features: a self-refilling shell that is easily cleaned and sterile. So non-jam valve that allows an oxygen inlet flow of 15 liters per minute. Non-rebreathing valve. So basically, what do you see the bags there? It's non-rebreathing bag, so it fills up and it has a one-way feature. Standard features: self-refilling and 15 liters per minute non-rebreathing valve. Mechanics: so supply of 15 liters per minute of oxygen attached and enters reservoir. So when we use a BVM, so we hook it up to the tank, oxygen tank, and we fill that bag up, and we do it at 15 liters. So non-rebreather, typically you can gauge, like a non-rebreather mask is different than bag valve mask, but you can typically 15 liters on down. A BVM is 15 liters, the air's flowing through, so they're getting passive airway too, and then when you're breathing for them, it gets that more power. When squeezed, air inlet closed and oxygen delivered to patient. When released, passive expressions by patient occurs. 2 rescue BVM ventilations, no trauma suspected. So what you do there is you strongly recommend 2 rescue BVM ventilations, no trauma suspected. Sorry, I had a kid walk in. But most difficult part of BVM ventilation is obtaining adequate mask seal. And that is a very complicated thing. People's faces are different, their noses are smaller and bigger, and it's hard to maintain that seal when squeezing the bag. So one rescuer squeeze bag, other rescuer maintains seal. So basically, if me and a partner on scene and their heart's beating and I don't need CPR being done, one of us will squeeze the mask while the other one squeezes the bag. When you're by yourself, it can get complicated to get a good seal with one hand while breathing on the other one. 2 rescue BVM ventilation, no trauma suspected, is open airway with head tilt chin lift. So same thing that we've been going over. Select correct bag valve mask size for them. You don't want too big of one or too small. Kneel at the patient's head. Position your thumbs over the top half of the mask. Index fingers over bottom half. And so get that. It's like a C grip. Fingers are under the jaw, thumb goes over. And then when it's 2 rescuer, place apex of triangular mask over the bridge of nose, lower mask over mouth and upper chin. Use middle ring and little fingers to bring patient's jaw up to mask. And that's the trick. Bring their jaw up to the mask to get that good seal. And you're going to have to muscle that sometimes, especially if it is a cardiac arrest, depending on how long they've been laying there. They do, their jaws get stiff. and then maintain head tilt chin lift maneuver. Um, Second rescuer connects and squeezes bag. Second rescuer releases bag. Patient exhales passively. Watch those chest rises so you know you're getting a good seal, and you're getting a good breath. Fill those lungs, alveoli exchange, all that great stuff. Perfuse the body. But again, you're only using their pressure. So if they're breathing, you're going along with them. If they're not, you're creating that breath. Two rescuers. So open airway, using jaw thrust maneuver, select correct bag valve size, and hold it close to the patient's face. So here we go. There's a picture of the two rescuers CPR. Um, you can see the kind of C shape there with the thumb and the fingers. So fingers are under the jaw, thumbs are covered in the seal, and boom, you're breathing. So one person, it's a little bit more complicated to get that seal, but it's not impossible. We do it all the time. So open airway, select correct size, form a C around the ventilation port. So what you do is there'll be a picture in your book of the one rescuer CPR, and so basically you use your hand to get that good seal. But since it's only one hand, it's tricky. I'm actually trying to find a picture in the book, but I don't see one, guys. Maybe you'll find it. But we did in class, same kind of thing. Your fingers are under the jaw. You're trying to get that seal on both sides of the mask while also holding the mask down with the thumb. Can get a little tricky. Squeeze bag, release pressure on bag, and let patient exhale passively. So breath, release, let them exhale passively, and it fills your bag. Your bag will fill back up on its own, and keep going. If the chest does not rise, which it'll happen, reposition the head. Make sure you get that head tilt chin again. Make sure that airway's patent. Check for escape of air around mask. Reposition the mask. Check for airway obstructions. Like I said, make sure it's patent. Nothing's in there, and just you do what you do. Basically, it's the rule of thumb is just you keep trying what you're doing, and make sure you're doing it right, and use alternative methods if needed. Clear mucus plugs or secretions from the stomach or stoma. It's a part of the bag valve mask. Artificial ventilation of a stoma breather. So leave head and neck in neutral position, and then use pediatric size mask to establish seal around the stoma. That would, and like all this chapter, we're gonna have to revisit in class. There's a lot here, guys. A lot. So ventilate at appropriate rate for patient's age. If unable to artificially ventilate through stoma, seal stoma, and attempt artificial ventilation through mouth and nose. And that's very possible to do. So, and basically, it's like when things are going wrong, you just keep maneuvering, keep doing what you can do to make sure to have good seals, good airway, all that kind of stuff. Also called manually triggered ventilation device. So flow restricted oxygen powered ventilation device. Okay, guys, I'm not sure if you guys recognize that I had to pause for a little bit. I had an ambulance call. But picking back up at the flow restricted oxygen powered ventilation device. This is a flow. In your book, it talks about this. This is not something I'm that familiar with, so I don't want to give you false information. So please keep referring to your book. But I believe this is another name for it that we call is PEEP valves, but I don't want to misspeak. But anyway, it's a flow restricted oxygen powered ventilation device, FROVP or VD. It's a manually triggered ventilation device. It uses oxygen under pressure to deliver artificial ventilations through a mask placed over the patient's face. This device is similar to the traditional demand valve resuscitator, but includes features designed to optimize ventilations and safeguard the patient. And I believe this is like I said, another name, I don't know. I've seen PEEP valves on BVMs that we don't use here yet. We need to get them, but it helps control the flow rate of those ventilations to keep the patient safe. But in your book, it's got a few bullet points on this. A peak flow rate of 100%, oxygen at up to 40 liters per minute, and excuse me, inspiratory pressure relief valve that opens at approximately 60 centimeters of water pressure, an audible alarm when the relief valve is activated, rugged design and construction. So just a few bullet points on there, but please um, read this. But it is kind of different. Like so, follow it's the same features as a BVM, but also it triggers the device until the chest rises, and then you repeat it every 5 seconds. If the chest does not rise, reposition the head and go through the same kind of situations as the BVM. We've never used this in our county, but for test purposes, please refer to this section a lot. You also only use it on adults. Um, then again, follow the same procedure. BVM, trigger device until chest rises, and there you can see one. And yeah, like I said, that's to me that seems more like an ALS procedure, and it might be because I've never used one in any county I've been in it yet, especially ours. But it'll be on the test, so make sure to look at that. Um, Automatic transport ventilator. This is for when we have paramedics in our county. I'd like to have that soon, but it provides positive pressure ventilations. It can adjust ventilation rate and volume. Provider must assure appropriate respiratory rate and volume for patient size and condition. So some of the stuff like the flow restricted oxygen power ventilation device and a ventilator, those are ALS gadgets. But a lot of EMTs work with paramedics. I mean, we don't have a paramedic in our county, but if you're at the ER, I've helped with ventilation and some of these things. But when I work with paramedics, I've used a ventilator and helped intubate and do stuff like that. So this will be on the test because they're coming at the angle of EMTs working with ALS. Um, but automatic transport ventilator, it's right there. Carries in the rigs for transfers um, and helps when you intubate someone and you have to RSI them, you can vent for them. So anyway, think about it. How would you decide which positive pressure delivery method to use for your patient? And that is a great, fantastic question. So please remember that, and maybe let's talk about that in the next class session that we have, because it is going to be very crucial to, one, know when to intervene with someone's having difficulty breathing, but also know when one thing fails, when to go to the next thing, and when to go to a CPAP, and when to, those will be needed to, you will need to know those things. So it'll be good for us to discuss those in a class setting, not necessarily over a recorded session. But keep that in mind. So oxygen therapy, boom. Supplemental oxygen, issues to consider when making decisions about oxygen administration. One thing to consider is oxygen is a drug. When I took my first responder class in 1999, a drug or oxygen was a drug and it was given all the time. Everybody got oxygen. But now we don't. We only use it when the person needs it because it can cause harm as well. Like we said, there's a point where we want to hyperventilate someone to a point where we're up in the respiratory rate so we can get those alveoli working to drop off the gas and pick up the O and get it transferring through the body. But too much can cause harm, so we want to keep that in mind. Oxygen should be administered based on your overall evaluation of the patient's presentation and possible underlying conditions. So that's where you gauge what oxygen to give or how to give the oxygen and when and that kind of stuff. So like a non-rebreather, listen, not every patient needs a non-rebreather. 2 liters of nasal cannula is suffice for some people, but also a nasal cannula may not deliver what it needs to with at a high flow rate. So high flow is a non-rebreather, but then maybe non-rebreather isn't working to get the pulse ox on. Now we want to think about albuterol and nebs, and so you do your overall assessment and evaluation of the patient. See what they're presenting like, cyanotic, shallow breaths, whatever, and possible underlying conditions that might be causing it, so we know how to intervene. Oxygen therapy equipment, portable in the field, lightweight, safe, dependable. We have little oxygen tanks that we carry. Then we have the ones that are installed in the ambulance. It's called the house oxygen, and we have a big tank set up in the rig, in all 4 of our rigs, and then we have the portable ones, and there's some portable. So I am in the process of setting up a airway bag in all 4 ambulances. Right now, the primary ones, ambulance 2 in Kit Carson, ambulance 1 in Cheyenne Wells, has an actual bag. It's straight up just airway. It has little tanks in it, but then it also has every single thing that we need, from eye gels to intubate and or tube somebody, to non-rebreathers, nasal cannulas, all that. And there's the house, right outside the ambulance behind the driver's door. We have a little door that we have all of our house oxygens on. And as we do on-call scheduling, when you guys are all done and graduated, every shift we like everybody to check the oxygens, make sure their levels are good, and we're ready to go. You don't want to show up to a bad scene and not have any oxygen. And sometimes these things leak, so it's good to check them out. So they come in various sizes: D cylinder about 350 liters, E cylinders 625 liters, or M cylinders at 3,000 liters. And all these will be on test. So remember, and then the G's 5,000 or more, and then 6,000 or more. Use pressure gauges, regulators, and tubing intended for use with oxygen, and that is a great thing. To use pressure gauges and to use regulators, just helps keep the patient safe, keep you safe, and all that great stuff as well. And like I said, there is certain valves we put on PVMs or BVMs, sorry, called PEEP valves that helps regulate that you don't give too much oxygen to the patient. We don't have those yet, but we're going to get them. Use non-ferrous wrenches on changing oxygen out. Firemen, those of you who are firemen, you change oxygen all the time at the firehouse. It's kind of the same situation here. You got to use proper equipment to do stuff. Ensure valve seat inserts and gaskets are good condition, and use medical grade oxygen. Open the valve of an oxygen cylinder. And these will be on test, so you will be required in the practicals to actually change these things out, use your regulator, do all this stuff. So open the valve of an oxygen cylinder fully, then close it half a turn to prevent someone else from thinking the valve is closed and trying to force it open. Just little twerks, to help us when we're on a scene to always be thinking alike and knowing when something is ready and not ready. Store reserve oxygen cylinders in cool, ventilated rooms, properly secured in place, and have oxygen cylinders hydrostatically tested every 5 years, and that's obviously for tests, but we'll take care of that as a department. Never drop a cylinder or let it fall against any object. So when you put a cylinder in an ambulance, make sure it's secure. These things are like missiles. If you break the knob off and the regulator off, I've seen these things fire through a brick wall. Never leave an oxygen cylinder standing in an upright position without being secure. And we have things in ambulances to properly store these things, and never allow smoking around oxygen equipment use. Never use oxygen equipment around open flame. Never use grease, oil, or fat-based soaps or devices that will be attached to an oxygen supply cylinder. So basically, there's proper ways to clean them. We'll go through them. Never use adhesive tape, and never try to move an oxygen cylinder by dragging it or rolling it on its side or bottom. Especially these things get heavy. You got the big ones that are for the house. We have dollies to use, and then never lift it alone. Connect it to the oxygen cylinder to provide a safe working pressure of 30 to 70 psi. We have all that stuff, regulators set up. So then there's flow meters. All control the flow of oxygen in a liter per minute. So low pressure flow meters, pressure compensated flow meter, and constant flow sector valve. Now these are things that we have on the regulator or on the tanks themselves. Then on the house and the ambulance, we have these set up against the walls and against the on the roof of the rig, and you can gauge how much oxygen you want to give someone and turn it so the flow meters will actually control the flow. So if you want high flow with 15 liters on a patient, you turn it to 15 and let it go, but it will regulate it so you don't have to monitor it. 2 liters nasal same thing. High pressure flow meters, thumper, CPR devices, respiratory and ventilators such as CPAP and BiPAP devices. Those are high pressure, same thing. You set it up, boom, it flows it for you. That way there ain't human error taking place as well. So, and there you go. That's the flow meters. Like I said, they're in the rigs, and the one on the right, those will be on the tanks themselves that we portably carry in the airway bag. Excuse me. And then the one, the green on the left, that's we have those on the wall of the ambulances by the airway chair and all that kind of stuff. So, there you go. That's the one on the tanks. And then there's humidifiers connected to flow meters, provide moisture to dry oxygen from supply cylinder. Sometimes people don't need necessarily nebutol treatment. Sometimes they just need some moisture. Most of this is done in the hospital, but we do have the capability to do it in the field and have done so. And there's a picture of it right there. You kind of hook it up. So you hook your tubing to that humidifier, and then hook it to the pressure valve, the flow meter, on the wall. And that person is doing 3 liters, and it'll humidify the air as they breathe it in. Common hazards of oxygen and oxygen equipment. If a tank is punctured or a valve breaks off, the supply tank can become a missile. And I've already said that. Seen them go through some brick walls. Not with EMS, but more scuba diving stuff. So you want to take care of it properly. Oxygen support combustion can saturate towel sheets, clothing. Oxygen and oil do not mix under pressure. Just things to look at for test purposes mainly, but also safety. Rare medical situations: oxygen toxicity or air sac collapse, infant eye damage, respiratory depression, or respiratory arrest. Um, those are rare. Basically respiratory arrest means they're dying and take care of them. But rare medical conditions, it doesn't really happen a lot. Oxygen toxicity or air sac collapse, never seen it. Infant eye damage and respiratory depression or respiratory arrest, I've seen those. But administering oxygen. So work with your instructor or follow your instructor's direction to understand how to use specific equipment. And we'll go through all this hands-on stuff as well. You will actually, in class, we'll do everything from CPAP to nasal cannulas, to get you all comfortable. But in your book on page 245 and 244, you see a lot of different pictures of how to use the equipment. Best way to deliver high concentration of oxygen is to a breathing patient. So there's a couple things. Non-rebreather mask. I had a guy tell me one time, that's all I ever use, and that's ridiculous. Non-rebreather mask should not be used for everybody. It's high flow oxygen. It is medication. So you got to remember, people think oxygen, we breathe it, it's safe. No, 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 no. That is not the only, not, it is medication. Deliver it wrong can cause harm. But you see the non-rebreather, it fills up that bag. So it kind of rebreathes the situation, and it delivers high flow of 15 liters. So provide oxygen concentration of 80 to 100%. Optimum flow rate is 12 to 15 liters per minute. And an actual thing that's not in class but interesting is if you go back to this lady here, so that bag, when you're doing an albuterol treatment, and we'll go through how to do that, but you can actually take that bag off and hook the albuterol connection right to the bottom of that bag, hooks to the non-rebreather, and it blows, and it puts all the medicine right in there. It's pretty cool. I did that a couple times. A paramedic showed me. Optimum flow rate is 12 to 15 liters a minute, and a new design feature allows for one emergency port in the mask to the patient can still receive atmospheric air should the oxygen supply fail. So that is a cool new feature. So basically, if your oxygen tank runs out and you're not in a place to get new, it can take the atmospheric air and help still take care of the patient. Nasal cannula. Best choice for patients who refuses to wear an oxygen face mask, because like I said, when you put masks on when someone's not feeling good, they panic, they don't feel right, it's scary. So nasal cannula is more comfortable for them, but you just can't get that high flow in a safe way. You definitely don't want 15 liters blowing up their nose. That's uncomfortable, but also dangerous. So 1 to 6 liters per minute is what you want to do with a nasal cannula. 24 to 44% oxygen concentration, and it's only for people that need a small amount of supplemental oxygen and cannot tolerate a mask. I've common with nasal cannula for me, I've done 2 to 4 liters, nothing beyond that. If it has gone beyond that, it's usually needing not a non-rebreather mask. So watch those things. It's very simple. A partial non-rebreather mask is pretty simple. No one-way valve and opening into reservoir bag. Delivery 40 to 60% oxygen at 9 to 10 liters per minute. So not the full high flow of 15. And delivers specific concentration. So oxygen by mixing oxygen with inhaled air. And some have set percentage and flow rate. Others have adjustable venturi ports, and we've never really used that in our area, in our expertise. So refer to your book a lot on that. That'll be harder for me to give you hands-on. We've just never really used them. But there you go, is a picture of it. Again, that's more of an ALS situation, but just gotta know it. That's a better picture. A tracheostomy mask. So you have to do a trach in the field. It's placed over the stoma or tracheostomy tube to provide supplemental oxygen. It's connected to 8 to 10 liters per minute of oxygen via supply tubing. I've never actually got the honor to do a trach in the field, so I've never done this. Have seen it done in class forms, But people have ports, so you hook them up. And again, this would be more when you're a paramedic or helping at the hospital. Um, and there's a picture of it. So that port would go against into the neck, and you would hook the device up to that tube so they can breathe. Um, Oxygen administration via non-rebreather mask video. Apologize that again. So go to YouTube, check it out. There's a couple different options to look at. And again, I sent you guys a text to some websites that somebody else referred to me. Take a look at those videos as well. Just absorb as much as you can and do your own research. Special considerations is facial injuries, bleeding and swelling can disrupt movement of air. Absolutely. You got a busted up face. It's going to affect how you're breathing, and your airway is not really that patent, so it's going to affect that. Aggressive suction and advanced airway maneuvers may be necessary. So suctioning and intubations and all that kind of stuff, might take place. Obstructions, foreign bodies can impede ventilation of patients. So, if there's a obstruction and the patient's not breathing and you're trying to compensate, but there's something down there you can't see, all that is something to take in consideration and determine how you're going to transport and take care of that patient. If unable to ventilate, always consider the possibility of an obstruction. So, like I said, there's not always going to be obstructions that you can see. And the rule of thumb nowadays is that we don't go fishing for it. But if you're having trouble breathing for the patient and you maneuver their head, head to tilt, you've done all the stuff you can do that and you got to consider the obstruction. Dental appliances. Dentures should ordinarily be left in place during the airway procedures. And Lori did a great job explaining why the other day. It just didn't dawn on me. But you take those teeth out, the face is no longer firm, and it's going to cause complications. So if you can leave them in unless they're part of the obstruction. Leave a partial denture in place if possible, but be prepared to remove it if it endangers the airway. Hypoxia often occurs rapidly. Children burn oxygen at twice the rate of adults. So when you gotta look at hypoxia. So with kids, especially like they say, they burn through it quick. It takes no time at all to see a kid crash. Kids go hypoxic quick, and if they're hypoxic quick, that means they're going to go in respiratory distress and failure quick. So just remember that children can be fine and then crash. Adults, you see it slowly happening at times. So account for both by the many automatically differences associated with airway. So just keep that in mind with pediatrics. They burn quick and hypoxia often happens. Ventilation to pediatrics, you want to avoid excessive pressure and volume. Use properly sized face masks and again, take your time. I mean, kids, you will panic. I mean, it is not fun to work on children on peds, but take your time to get the right mask to seal properly and I'm telling you, just don't panic. Flow restrict oxygen powered ventilation devices contradicted. So you don't want to use those things on kids. They can be dangerous. Their airway is, like I said, some peds, infants, it's a coffee straw. Well, imagine what the lungs are like and the alveoli. It's all tender, so you don't want to be pumping a bunch of air in there and blow their lungs. Use pediatric size non-rebreather masks and nasal cannulas. We carry them and all the rigs, and we don't carry as many because we don't as we do adults because we don't see this very often, but we do have them and you want to use them. Gastric distension may impair adequate ventilations. It's very hard to breathe for an infant or a pediatric and not get that gastric distension. So you just want to be careful because if you do get it, it will affect how they're breathing. So assisting in advanced airway devices. So that's where you're kind of working with ALS. Device requirement direct visualization of the glottic opening, endotracheal intubation. That's what it's all called. So devices inserted blindly, meaning without having to look into the airway to insert the device. And there's a picture of someone being intubated right there. I've helped with this a lot. I've never had the opportunity to do it, but it's a cool thing to see. Preparing the patient for intubation is maximize oxygenation prior to procedure. A lot of times the paramedic will say hyperventilate the patient, which means just get their oxygen rate up. So if they're pulse oxygenating at 74, but they shouldn't be if you're breathing for them. But what you want to do is get them just above normal pulse ox level. So if 95 is where they say in the book to be at pulse ox, you want them at 100 because you're not going to be breathing for them as you're intubating and they're going to drop. Position patient in sniffing position. And then cricoid pressure, you want to take care of that they put pressure on that to know where they're going. And then conformations, you put the tube in and then you're bagging for them and you want to listen for breath sounds, look for chest rise, confirm that you're in there, and then they secure the tube in place. Very little movement can displace an endotracheal tube. It's a pretty cool way to go. With everything we do with king tube, compi tube, eye gels, um, it's just not as secure as intubation. Intubation is the best way to go when need be. Pay attention to resistance to ventilation, report changes. So anytime that you're bagging someone that's intubated and the pressure changes, you're having a hard time getting in air movement, report that change because there may have to be adjustments made. If patient is defibrillated, carefully remove bag from tube. Watch for any change in patient's mental status. That's kind of hard to do when they're unconscious, and you usually don't intubate someone who's not unconscious, but just watch for any changes in mental status. Assisting with trauma intubation, provide manual inline stabilization throughout procedure, and then position hands to hold stabilization, but allow for movement of jaw. To go refer to your book a lot on this section here. There was a lot, and I mean a lot, to cover. I don't want you sitting here at the computer for 2 hours. There's some examples is blind insertion airway devices, king tube, king LT, and then airway. We do that. King tubes we carry, laryngeal mask airway, LMAs we can do. Usually do not require head to be placed in sniffing position. So there's just a little bit less that we have to do to use a king tube and an LMA mask, and it's just more of a BLS procedure. So we'll do some of those hands-on in class. So please just go, I keep saying that, but keep referring to your book on those things. Anyway, yeah, I'm just looking at the material. Again, look that up. Good stuff. So I want to say, just as we close with the LMAs, this stuff changes so often. Right now I've said a lot about eye gels. That's going to replace the LMAs. I've seen LMAs inserted, and I've seen them work and not work. But basically, the bottom line is anything that we put into the patient, we're replacing their airway. That's what we're doing. So we put them in with intubation, where it's an LMA, a king tube, a compi tube, an eye gel. We're replacing the airway for those patients. And then we're breathing, and we're breathing, and we're breathing, and watching those things. So really good to know all the ins and outs. And I'd be curious for you guys when you pass, what ones you prefer us to carry. Some prefer eye gels, some prefer king. So anyway, that's that. So chapter review. If there's any questions, please let me know. Respiratory failure is the result of inadequate breathing that is insufficient to support life. So when they're not getting their proper ventilations, and the ventilations is not getting into the lungs and getting to that alveoli and dropping off gas and picking up O2 and taking that O2 to the hemoglobin and taking it throughout the body to the cells, the body is not going to get the oxygen it needs, and then it can't support life, and they're going to crash. A patient in respiratory failure or respiratory arrest must receive artificial ventilation so you can get that ventilations up. And the point of is just that right there. If you can get that anatomy part, guys, with the ventilations and the alveoli gas exchange and O2 pickup and taking it to the cells and taking it to the body, to the perfusion, all we do with the ventilations is replace that mechanism so that body can make it. Get that, you'll get through the class, get through the test. Oxygen can be delivered to the non-breathing patient as a supplement to artificial ventilations. So anyway, yeah, just take a look at those. And if you have questions through this chapter, please re-listen to the video. And I'm sorry. I hope this works for you guys. And we'll see you guys in class and go through it. Okay. So I appreciate you guys' patience as we learn all this together. And we'll see you on the next class.